Health Science Network. Firstly, thank you all for coming today. I do realise it's often difficult to find the time to come and have sessions like this. So I think we've got a really interesting agenda for you today. Next slide, please, Vicky. So I'm just going to quickly talk us through the housekeeping. Then I'm going to tell you a bit about the AHSN and what we do and how what we can do can help you address elective recovery. Then Professor Tim Briggs and Graham Lomax will update on the Getting It Right First Time GIRV programme, with a particular focus on the work they're doing around supporting systems and regions in relation to elective recovery. And then Liz Lingard will discuss the National Health Inequalities Programme and how our systems are progressing this agenda to build back fairer. So housekeeping. Next, thank you, Vicky. Do put yourself on mute, please. Everybody has distractions if you're not lucky enough to be in the office. Please feel free to turn off your camera. Equally, feel free to keep it on. We will be recording the event and we'll be circulating the recording and slides, making them available after the event. And there'll be a Q&A session at the end of the talk. And please use the chat function to ask your questions. And please also use the chat function to make connections with other people or to share what's worked for you, what hasn't worked for you. I think we get the most out of these sessions when people are talking in the sidebar. So that was it for housekeeping and for the introduction and agenda and so on. And if there is nothing that people want to shout about in the chat bar, I will move on to what the AHSN does and how does it work. Next slide, please, Vicky. So the Academic Health Science Network, there are 15 located in England. We have a clear focus on driving the spread and adoption of health innovation, increasing economic growth and improving outcomes for patients. So each individual AHSN operates on a local and regional level, but fundamentally we operate as one large interconnected network of networks, and we work together to spread insights, learnings and innovations. And that is what the network is. So as an organisation, all AHSNs are about spread and adoption of innovation. We share our learning about what works and what the needs of the system are. And that means we're quickly able to identify potential solutions and implement them for the things that the NHS needs. Next slide, please, Vicky. So as a network, we've delivered a range of national programmes which have been developed regionally and then through the network have been delivered nationally. So this work has benefited more than 48,000 patients, including over 2,300 children with ADHD and 264 young people with eating disorders. Our atrial fibrillation work, which isn't on that slide, helped prevent almost 12,000 strokes and saved almost 3,000 lives. And we generated £462 million worth of inward investment for the UK economy over the last 2 years, creating 700 jobs. So we're able to achieve these impacts because we share a set of national commissioners and a set of national priorities. And these are around adoption and spread, support for life sciences industry, and that includes SMEs and individual innovators. And some of those innovators come from within the NHS as well as from outside. We support local economic growth. We identify and promote new technologies, things like artificial intelligence, and the thing that I can never quite say right, robotic process automation. And then we support research and evaluation to make sure that promising innovations are evidence-based. Recently, we've added in the green sustainability agenda, and obviously a shared priority for everybody has been the response to COVID. So during COVID, we rapidly changed the activity of the network to support the pandemic response. So examples of the work that we did includes supporting GP practices to take up virtual consultations. So you can see on the slide that there were over 21,000 views of collaborative webinars that we did to support this kind of activity. We supported the spread of electronic repeat dispensing in primary care, the delivery of the COVID oximetry at home programme and COVID virtual wards, both of which involved technology that allowed people to be cared for or monitored at home while still connected to a clinician. We supported the rollout of tracheostomy toolkits because there were more tracheostomies while COVID was going on. And 92% of trusts implemented at least 3 of the various bits of our programme. And we rapidly evaluated the impact of changes in the system. So working out what we've done yesterday to inform tomorrow. And then the focus for 21-22 is to support NHS stakeholders with transformational recovery and identification of innovation that have a significant impact on waiting lists and patient management. Next slide, please, Vicky. So that's what the network did, but what you're interested in is what Yorkshire and Humber AHSN delivered for you and for your patients and organisations. So this is just a snapshot of what we did over the last year. And you can see on the slide our impact report, which goes through more of the stuff that we did. So we led and supported bids for funding that have resulted in over £5.3 million worth of new healthcare investment coming into our region. I've just mentioned the COVID oximetry at home and COVID virtual wards. So the care at home agenda is really interesting. And throughout the last year, around 1,500 people in northeastern Yorkshire were able to be cared for in their own homes. And through support for our virtual wards, COVID virtual wards, 134 people were discharged earlier. So as I said, both of these projects involve the use of technology to allow you to be monitored at home, keeping out of a hospital setting, but in touch with the clinician so that if there is any deterioration, it's quickly picked up and you get the appropriate care. Through our work supporting an objective assessment of ADHD in children, 1,123 children were diagnosed more quickly. And the test reduces the number of appointments to diagnosis, so we also save time and money for the NHS. PLGF is a diagnostic tool for preeclampsia, and this is quick and easy. And when the rollout of this meant that 1,100 pregnant women could be kept out of hospital where they were low risk. So they could go back home to their families instead of spending time in hospital. And this also saved around £1.8 million of cost to the NHS. And then during COVID, we helped ensure that staff had adequate supplies of PPE. We worked with around 200 new suppliers to make sure that they met standards. And this was really interesting because it morphed into a network project, an AHSN network project around reusable PPE. So we did a pilot on reusable PPE, finding that it used 41% less water in its manufacture, 66% fewer emissions, 28% less energy, and saved around £1.54 per use. So that's what we've done, but I'd now like to look a bit into the future, into this year. Next slide, please, Vicky. So we use our network position to identify the innovative solutions to some of the problems facing the NHS around elective recovery. And you know better than I do what they are. Supporting waiting well, improving patient flow, delivering post-surgery recovery and rehabilitation, workforce challenges and so on. So I just wanted to talk you through a few of the projects that we're doing. So we all know that the pandemic exacerbated long waits for cancer diagnosis and treatment. So this is Dr. Masur. Dr. Mansour is a real patient in Yorkshire and Humber. He has patients whose symptoms could be indicative of cancer, but he's not quite sure. So Dr. Mansour sends the patient's blood sample to an NHS path lab, where a machine learning algorithm combines signals from a range of blood measurements to produce a calibrated probability of cancer. The test shows his patient is low risk, and therefore he's able to rule out the urgent care pathway, releasing valuable secondary care resources. So Pinpoint Data Science, based in Leeds, have developed the Pinpoint test using artificial intelligence to provide that calibrated probability of cancer. And we're working with cancer alliances to test this in a real-world setting and see whether it does indeed reduce waiting lists. See the Signs is an AI platform to accelerate early cancer detection, which manages the referral process and patient outcomes. And we're currently implementing this in South Yorkshire and Bassetlaw with our Innovation Hub, Joint Innovation Hub, supporting evaluation. Next slide, please, Vicky. But what about home testing kits? So this is Sarah. Sarah has anemia as a result of chronic kidney disease. And she was going to go to the beach. And instead of having to cancel her family day out due to having to attend a hospital appointment, she can now self-test her haemoglobin levels at home. Their specially designed app lets her record and send results to her healthcare practitioner, who can plot the progression of her condition and take this into account when prescribing or adjusting her medication. So instead of having to go to the hospital and see a consultant to discuss her results, she can enjoy her trip to the seaside, and hospital services are freed up for those with more urgent needs. So a company called Entia have developed the Luma device to allow patients with anemia of chronic kidney disease to test their haemoglobin levels at home. And they've already piloted their product on patients in Hull. And Healthy.io is another company that developed at-home urine testing for a range of health conditions, including kidney problems and diabetes. And we're supporting this being trialled in Leeds. Next slide, Vicky. So John has always been a keen runner, but recently he's had significant joint pain. I really empathise with John here. He needs a knee replacement. Waiting lists for face-to-face appointments are long, and he knows that seeing a physiotherapist is going to delay his operation, and afterwards he'll have to wait to see a physio for his rehabilitation. But John can receive digital prehabilitation before his operation and digital rehabilitation after his operation, and that reduces the need for face-to-face appointments with a physio and speeds up his journey to lacing his trainers again. So we are supporting Hull University teaching hospitals to implement Physio Buddy in their area, with evaluation being completed in the region by Yorkshire and Humber Yorkshire Health Economic Consortium. Next slide, please, Vicky. This is Sandra. Sandra has multiple long-term conditions, and her GP refers her to a specialist. She is also a frequent user of unplanned care services. AI algorithms identify Sandra as a high user of NHS services, which could be unnecessary if she was supported to manage her condition better. She receives personalised health coaching from registered health professionals, and as a result, she doesn't need to access services as often. So these services are provided by a company called HN. It's currently been piloted in Humber Coast and Vale ICS. When HN's clinical coaching was implemented in the Vale of York CCG, we saw a 34% reduction in AE attendances from high-intensity users, 24% reduction in non-elective admissions, again from that particular cohort of people, 24% in elective admissions, 16% improvement in general health, and a 33% improvement in patient activation. Next slide, please, Vicky. So this is just a small amount of the work that we're doing. We use improvement techniques in our work. So this is badged as improvement and innovation. So for example, we're working with West Yorkshire and Harrogate ICS around outpatients transformation, and we bring together those involved from each trust to get as a learning network to share what they've learned, use quality improvement techniques to refine, to iterate. And we've seen real results from this approach, and we're extending it into other areas. So if you would like to hear more about innovation and improvement for elective recovery, please come and talk to us. We can help identify innovations that might meet your need. Sign up to our newsletter. The link's on the slides. We send out a Health Innovation Exchange newsletter regularly, which in July is all about elective care. Look out for our events. We're planning an autumn event around innovation and planned care. And we're establishing a quality improvement network across Yorkshire and Humber. And please do get in touch if you would like to be part of this. Thank you very much for listening to me. And I'd now like to hand over to Professor Tim Briggs and Graham Lomax. Thank you.
So thanks very much indeed for welcoming me. So let me ask Graham to introduce himself first, and then we've got a short slide deck to show. Graham.
Morning all, I'm Graham Lomax, I'm the National Implementation Director for GIRV.
Lovely. So have you got the slide deck there, Graham? Thank you. So can I just say thank you very much indeed for inviting us along to talk through a programme that we piloted in London but is now becoming a national programme, and it's how we drive right at the vanguard of elective recovery, and I just want to share that with you. So I'm an orthopaedic surgeon. I've been a consultant almost 30 years, and I'm now the National Director of Clinical Improvement and have run the GIRV programme. Next slide, please, Graham. So for those that remember about the GIRV programme, what it was, it's 40 specialties, and what it has done across those 40 specialties, it's allowed us to demonstrate in each individual specialty what good looks like. So it gives us a very good baseline on how to drive change as we go forward. The way this came about was that in February 2020, at the height of the first wave, I was asked to get involved in London with Sir David Sloman and Vin Dewaka, the regional director and the regional medical director, to transform surgical services, because we knew that even before COVID, we were struggling during the winter months, and we were actually seeing increasing our waiting list. And so this was aimed at reducing variation, but also taking on 6 specialties: trauma orthopedics, including spines, ophthalmology, urology, ENT, gynae, and general surgery, which account for about 50 to 60% of waiting lists, and then use those specialties and then define what the high volume, low complexity group is across 29 pathways, focusing at system level to drive equity of access and excellent clinical outcomes for the population. What we didn't want was average, and that's why the GIRV program was able to give us that information. Well, what does good look like? And what we decided to do across those specialties was to drive for the top decile in GIRV performance in terms of clinical outcomes, productivity, and equity of access. But that was the start, and what we wanted is year-on-year improvement from that. We also wanted to standardise clinical pathways, something that we'd never achieved since the NHS was founded in 1948. And so could we do that? And what we developed was clinical groups to do that, and I'll talk to you about that in a minute. And the other opportunity that we were given was to develop fast-track surgical hubs where we could. I've been pushing hot-cold sites split in orthopedics for a number of years, and wherever we've done them, they've been very successful, both on the elective space, improving productivity and efficiency, reducing length of stay, etc., and also on the acute space, because the senior decision makers are there when they have to be. And then what we wanted to do was agree again principles in theatres. And again, I was part of a report in 2018 which looked at orthopedics and other surgical specialty delivery across the country, about start and finish times and turnaround times. And what we wanted to do here as a result of that was to set the principles when we start, when we finish, turnaround time between cases, and how many cases on a list. So we were setting a new standard. Next one, please, Graham. And this fits into the pathways. Everybody heard about the end-to-end pathway piece. So if you look, we're the rectangle in blue. So we are there at the vanguard, driving 29 pathways across these specialties. And then what we've done with those pathways that we developed, we've done them end-to-end. And now this group, led by Hugh McCackey, is looking at the end-to-end pieces, the primary care, etc., the follow-up at the end, as around eye care, MSK, and cardiac services. So you can see how the two blend in together, but we're there absolutely delivering in the secondary care space now and trying to get things moving. Next one, please, Graham. So the key was design and implementation of the procedure of clinical pathways, 29. And what was amazing to me is we did that in 7 weeks. And if you'd said to me pre-COVID, how long would that have taken? I'd said probably 29 years, one pathway redesign a year. I'd have then retired thinking, well, you know, we've done a pretty good job. But we had 200 clinicians on the call when we first started this. And what's been great about these pathways, they're now being signed off by the colleges, the specialist societies and associations. We then set the outcome, top decile for clinical outcomes as the new norm, with a year-on-year improvement. And we developed a gateway process for the first time to allow systems to see where they are in relation to the top decile and what they need to get there. We've also established clinical, bottom-up clinical driving this, regional specialty clinical leadership groups to work with system leads to absolutely drive it. Because if clinicians don't really grab this and work this and drive it, then I'm afraid I think we'll struggle to make it happen. Theatre principles, already said that. So what we've set the new standard, for instance, 10 cataracts on a half-day list, 4 joints, cemented joints on a full day list. Those are the minimum. And if we can get to those around nationally, then we'll make a big difference. Just by doing that in London, in cataracts, we can increase the throughput of cataracts by 33%. And then again, as I said, fast track surgical hubs, which are resilient, safe for patients, safe for staff, etc. So the timeline approach, just look at the middle line there, the vertical, where we went in 4 months. It was absolutely phenomenal with the buy-in and that we got. And the key to it is having a good PMO, a good senior responsible officer, a good chief executive who's going to lead it, good clinical leader overseeing it, and we are there to help with that, to design and then deliver it. Next one, please. So these are the 29 pathways. And what is crucial is that as we move forward, we want to see all of surgery to be day case where it can, and we think over 80 to 85% of all surgery can be day case. In this group, we want about 90 to 95% to be day case, understanding we've still got a bit of work to do around total hip and total knee replacement, but more and more people are developing pathways that allow this to be done as day case. And so this again has got buy-in, and these pathways have been standardized, and we're very excited about that. Next one, please. Graham, next slide.
Is that changed?
It has now. So this is just an example of the pathways that were developed in a very short time frame. So this is shoulder arthroscopy, so it's a subset of my specialty. Look how comprehensive they are in terms of end-to-end, right from first presentation to GP, right through to discharge and follow-up. And we're focusing for this piece on the middle bit, but it allows us to work with our MSK, first contact practitioners, etc., primary care, about the work in primary care, and then how we follow up these patients after discharge. So they are very comprehensive and work extremely well. Next one, please, Graham. So the gateway process for me is really important. So the 3 elements are, we've got the pathways, we've got the conversation with the clinicians, and then we've got to use the gateways to actually look at system level to see where people are in relation to where we want to get to. So this is the GIRV data set has allowed us to do this. Aggregated system level data, it breaks down to trust level, system level, national level, and then we have a gateway review meeting, which is led by the GIRV lead, which looks at what you're doing, where you are, where we want you to get to, and these meetings become very, very important. Next one. So we've got elective hub models here. You can see that the elective hubs can be different as they have developed in London, but ideally where we want people to be is to the right-hand side of this group of hub sites. If you get them isolated, if you can, or they're separate, they can be on the same site as the hospital, but they're separated by walls and doors, they go through separate entrances, then they're resilient, they're safe. PPE doesn't become a big issue because you've got the testing situation, and it has led to significant improvement in flows, patient experience, efficiencies, and activity. So you can choose a different model, but ideally for staff, we want, and patients, we want to be as far right to that as we can. Next one, please. So this is what we achieved in London. So this is where it got the national attention. So ophthalmology, top left, is the our latest position with 52 weeks in terms of ophthalmology with the blue line, and then in orthopedics. So we were able to make significant indents into orthopedics and ophthalmology before we got smashed again by COVID at the end of December of last year. And just to show how in other systems, other regions, people have been able to do things using the same methodology. Look at the bottom right. This is the Nuffield Orthopaedic Centre in Oxford. And just by adopting all the metrics, the day case rates, the theatre start times, productivity, the pathways, etc., they have put through 25% increased number of cases per week through their same facility without actually extending it. And we've also seen examples of mutual aid, where trusts within the same system have got longer waiting lists to trusts that have lower waiting lists, which is a really good thing to see. And we've also seen mutual aid across systems into different systems if there's a real big issue, as well as trusts like Barking, Havering, and Moorfields doing drives of bone blitzes. They did 151 joints in a week. Moorfields did almost 800 cataracts in a week. Just absolutely rammed through to get on top of the waiting list. Next one, please. So have we moved the dial in London? Yes, we have. I mean, everybody used to tell me, well, London, our patients are different, Tim. Well, they're not. And if you look at where we've come from, that's hip and knee replacement length of stay, with the black line being the national trend. So London was worse than the national trend. But look what we've engendered. Look at the gradient of the decline in length of stay on both, how we've absolutely broken the mold and now got London to understand, you know, you're not different from anywhere else in the country. Actually, you need to be where they are. And we've seen huge change. Next one, please. And this is the example that's worked really well. I've always pushed the hub site in orthopedics, splitting hot cold. This is Croydon, that has the hub site on the same site as the main hospital. But as I said, separate entrance, goes into it, completely separated from the rest of the hospital. And this is what they did. They did it in 5 specialties out of the 6. They didn't do it in orthopedics. And look at what they achieved. Just by running these cases through these hub sites, they got to 100% of BAU using 9 theatres rather than 11, leaving an extra 20 sessions a week, fully staffed already. So they're working the staff smarter, not harder. And this again has had a significant difference. And so what it's done, it's allowed efficiencies, productivity, etc. And also then when you look at the emergency workload, the emergency workload has also improved. They got their cholecystectomy rate on acute admissions from 30 to 80% because the senior decision makers are there in the room. Next one. And again, this is the one at Barking, Havering and Redbridge. Look at that. They did a bone blitz for a week. They normally did 51 joints in a week. Their target was 100. They did 135. So real, and the morale amongst staff was fantastic. I actually went to it when they were doing it. People talk about the staff being tired, dispirited, what have you. Getting back to doing the job they love and that they normally do. The morale was absolutely amazing. Next one, please, Graham. So you can see that success really is based on leadership, engagement, evidence and communication. Clinical leadership is absolutely crucial. Working together with management within systems and across trust, working in a very different way, with shoulder to shoulder, where the patient is right at the centre of this new methodology. So let's use clinical leadership. Let's be guided by the evidence. We've agreed the key principles, and let's use recovery really to develop our nascent systems and redefine the region's role. Next slide, please, Graham. Over to you.
Thanks, Tim. Yeah, so just building on some of the case studies Tim mentioned here, there's a link, and we'll share these slides. Anyone interested in theatre productivity and efficiency, I'd suggest you find 20 minutes to watch the GST presentation. Really quite impressive stuff with high impact theatre lists. Some of the lists have only got 9 minutes over a whole day of downtime, incredible numbers that they're getting through with good quality outcomes, of course. The Oxford presentation is the example that Tim alluded to earlier, with about 25% more capacity created through, frankly, quite good old-fashioned theatre improvement with clinically led, pathway-driven, data-driven approaches. And then also, Tim also just mentioned the increase in the day case approach for hip and knee replacements. Wrightington, we've got a good example, although close to home in Yorkshire, Calderdale and Huddersfield would be another example of where they're pushing the boundaries, really. So other case studies on that link there, the best practice library of GIRV, and there'll be a lot more to come on that site over the next year or so, well, next few months. So just to aggregate, so Tim's talked a bit about the variation we've seen, and just to aggregate some of those opportunities, so just a couple of pathways so you can see the level of materiality. So we've seen the length of stay for, Tim showed the national trend for hip and knee surgery coming down. Overall, there's over 250,000 bed days, sorry, nearly 250,000 bed days still to play for. The hip fracture work was quite astounding in London, I have to say, in terms of the levels of variation were unbelievable. Just nationally, to get down to national top decile would be 279,000. If we can get down to that best practice level, it's over 500,000. And that is relevant, and we'll show a slide in a minute with the Northeast. There are 1 or 2 systems where that would look like a good opportunity. The badge rates, and frankly, we should have been doing this years ago, shouldn't we? But you can still see the level of opportunity there in a situation where we all know right now the beds and flows are increasingly challenged. And yet we know there are good pathways there to deliver the good quality of care day case. And then going into the non-elective pathways, so just 3 pathways there: COPD, asthma, pneumonia. You can see close to 200,000. So as we extrapolate that across all the medical specialties, you get really, really big numbers in terms of the beds that could release and provide capacity for the elective challenges. And then Tim mentioned, so we've got we have specified for all the 29 pathways, we've specified how many cases we believe should be done on a theatre list, and of course that's coming from the practicing clinicians on the ground, including training, I should say, as well. And we'll be doing a specific follow-up paper about the surgical training, because that's a really important part of this, and this is an enabler to training rather than a hindrance. So the cataract pathway there, so if we can do the same number of lists as our baseline, but adopting the cataract pathway, and therefore the numbers of cases, again including training, that's 99,000 cases nationally. So we can see there's some real opportunities within our existing capacity, and then that helps make sure that the investment we need for further capacity is directed appropriately. So just a quick word. So this kind of transition really from the more trust level data or focus to a system level focus, we've had to adapt our data flows to enable that. It's also much more transparent now, so we can easily flick. If you're in a trust in your system, you can look completely across the piece, see any trust in the country, and where you are against that distribution. So we have created in Model Health System the gateway metrics. So that's the particular kind of sentinel metrics relevant to the specialty. Obviously, we've stuck with there's the day case compartment in there as well. And indeed, there's the theatre component, and that's going to become a really important rich data source over the coming months. That's becoming or has become mandatory, and again, increasing functionality to come. So we'll be able to be a really important intelligence source for us. But we're actually going to bring that all together. So we are developing an HPLC dashboard, so the specific procedure code, so we can get right down to the procedure codes we're talking about, looking at the volumes, looking at the sentinel metrics, so we can have a really clear view of the impact we're having, and support trust systems to drive that. So by the end of July, that will be in place, and we've got more and more coming all the time. So I'm just going to whiz through a handful of examples. So as I say, you can go into this and cut it any way you want. So you can look at the national distribution, the system or afflicted trust level. You can also look at the trends, so you can go back and look at pre-COVID, post-COVID, whatever, and also the numerator and denominator, so to get that kind of sense of materiality. So we've added the horizontal line there is the top decile, so the blue is what we are recommending, which is about 2.7 days on this metric, which is average length of stay for primary hip replacement. So we can see, so this is all the individual trusts across the Northeast region. So you can see we've got Northumbria, York and Calderdale in particular, who are really at the front end of this from a national picture and really driving that level down. But then you can see that full distribution right to the end there, which is quite significant. If you just look at the numbers, when you talk about the volumes of surgery we're talking about, this is really quite big. And some of these, of course, again, when you're in system conversations, you can see the level of variation between trusts that are neighbours. And again, the opportunity there of establishing that same pathway, taking what's working well, taking the best bits from all the services. And again, you don't have to go very far. I think in most of the regions, they've got the answers if we can just roll it out across the neighbouring trusts. I mentioned necrophema before, and again, if you just look at that, the y-axis there, so you can see we've got a number of trusts at the top decile range, about 12 days or so, but then equally we've got some trusts double that. So, and the actual average, I think, for certainly one of the systems is over a week more in hospital. So again, the cost, the impact to the patients, of course, in terms of their rehabilitation, and the capacity that's taken up is obviously significant. So if we can share some of that learning, the pathways we've developed in London, clearly it will need to have an appropriate to be tailored to regional circumstances, but that's fine. Let's have a system model or a regional model. So readmissions there again, a huge variation from 2% up to over 12%. Day case for TURBT is always an interesting one. So BADS and BAUS and GIRV would say it could be up to 60%. We have got one trust of Sheffield are actually pushing at that rate. Yet again, we can see various trusts where it's single figures. Here we've got the minimal access rate for hysterectomy. So this is the Gynae Gateway has only been published quite recently, so this is quite new data. So again, you can just see the variation in this is about access really for patients and what is the right pathway. At the moment, that seems to be determined by whereabouts you live rather than anything else potentially. Length of stay for hysterectomy there, again, you've got a kind of cluster of trust around the 2-day mark, but then you can see that kind of jumping up to 3 times that potentially. And just a quick one on non-elective, because of course, although we're focused on the elective, you can't really separate them where you can't really separate the two easily, as with NOF. And likewise with the ENT, you can see this is the proportion of patients that are admitted without a procedure in, and actually if we get these kind of surgical ambulatory care models, etc., we can get that right down. And again, we've got some trust in the region who seem to have good models. So as Tim said, the gateway process. So this is the pure data. We know there will be context and needs interpretation, and that's where the power of the clinical conversations with clinicians like Tim and our other national leads are really important to understand the warranted versus unwarranted variation and what we can start to do about that. Just wanted to finish with a bit of a trend there, though. So actually for the BADS basket of procedures, you can see that trend, and we did produce a document, so GIRV with CPOC, so the Centre for Perioperative Care and the British Association of Day Case Surgeries did a joint report last year, a really practical guide on day surgery, and hopefully some of you will have seen that. And we can see that impact of jumping from a baseline of around about 78% up to knocking on 84%, and I think that's probably one of the strongest regions nationally. So, so a really good example of what's in the art of the possible.
So thank you very much indeed for that. So if you just look at that data that Graham showed, that data is so powerful. At the moment, it's every quarter, but it's going to be every month. So if you just look at my specialty, orthopedics, and look at the data that Graham showed around length of stay for hip replacement and fracture neck of femur, right? If you had a fracture neck of femur length of stay of Hull and East Yorks, which was the best in class, as well as having a length of stay for hip replacement that was equivalent to Northumbria and York, you would absolutely, across Nancy, completely change your orthopedic flows and your emergency flows for patients. So, and if you look at within what Graham showed, there's examples within your system of people doing things really, really well. So you don't have to go very far, what's interesting, to learn from each other, to find out what are you doing that's right that we can introduce into our trust that will actually change the way that we do things, reduce our length of stay, get better outcomes for our patients, etc. So a lot of the information that we get now is going to absolutely drive change with the clinical voice, our help, looking at systems, because we will be looking at this data all the time. And one thing Graham didn't show is he didn't show any theatre data. The theatre data returns are now mandated. We'll be able to look at start time, finish time, turnaround times, volume of procedures going through. So I think it is a very different environment that we're in now, with clinicians driving it, clinicians having the conversation, working with the systems, enabling this program which is regionally led. So we're really quite excited about it, and I hope you can see how we can get real value out of what we deliver to patients to improve better care. Thank you.
I can see a few questions in the chat, Kathy. Do you want me to pick some of those up?
Yes, why not? Let's do those, and then we'll move on to Liz rather than having the Q&A at the end. Was there any particular one you wanted to go first?
Well, I was going to start with a couple of things, Tim. One is to maybe build a little bit more on the training. There's a couple of questions on that.
So I'm very aware of that, and two things I'd say about that. One is when we've set the standards in theatre, 4 joints a day, we'd expect that to also include training. Cataracts, we said 10 cataracts on a half-day list if it's non-training, 8 cataracts if it's a training list. We're also going to work with the independent sectors. I think everybody realises we're going to have to, because we've got 5 million on a waiting list, then we've got a hidden waiting list, probably of over 2.2 million. But the good news is they've agreed to adopt all the pathways, the productivity, etc. And we're having conversations with them at the moment that it must also include a training element for our trainees. So I'm a training program director. I've got 50 trainees. I'm very aware that what we've got to make sure is the next generation of our surgical colleagues are trained properly. But actually, I think this is a real opportunity, because we're going to put our trainees in theatres. We're going to expect the top decile in terms of outcome, theatre productivity, efficiency. Therefore, our trainees are going to learn how to do things really well. And all I can say is, given the variation that I saw pre-COVID around the country, then training everywhere was not perfect. So this is a chance to standardise it at top decile if we can get it right.
Tim, there's probably one other one. We'll pause health inequalities till after Liz, but there's a question from Jake around, I guess, translating outside of London. So it works well in an urban setup like London. How does the model translate to more rural parts of the country? What's patient feedback about having to travel long distances? I wonder if you want to mention United Links, perhaps, or
so let me just talk about United Links. So United Links, which has 4 hospitals within its trust: Boston, Lincoln, Louth, and Grantham. They had a real problem with cancelling 900 joint replacements in 1 year, of which some of them were cancelled 2 or 3 times. Morale was terrible amongst patients and staff, so I was asked to go and come up with a plan and introduce that across there. So I went there. We made Grantham the cold site where they did their elective orthopaedics. That meant staff and patients had to travel there 35 miles from Boston, 35 miles from Lincoln, 50 miles from Louth to Grantham. Over the next year, they became exemplar in length of stay, down to 2.4 days. Productivity went to 5 joints a day. Morale was fantastic. There wasn't a single complaint from a patient. They were just delighted to have their operation. There wasn't a single complaint from staff. They were really pleased. And before COVID came, they were then going to introduce the similar sort of methodology into gynecology and urology. But then COVID came. But no one where we've done it wants to go back to the old way of working. So it can work extremely well. But I accept distance and geography is an issue. But where we can, if we centralise in hub sites, we will actually maintain elective flows all year round. We'll be safe for patient, resilient and robust. And I think it is the right way forward where we can do that.
And that does link into a question from Helen Barker, who's saying it would be really helpful to understand the patient voice in the planning and what patient feedback has been obtained from this work, as that will be helpful in local conversations.
Okay, Graham, do you want to answer that?
Yeah, so the work started in London. There was a process led by the medical director around a kind of deliberative dialogue, so engagement with Londoners around what was important to them, etc. So it was a really comprehensive document which we can share, and that was our founding principle. So all stages through the development of the pathways and establishments of the hubs, they were kind of developed alongside those. So that's been the continuous piece. I think more we've also, of course, involved the societies, and some of those have well-developed patient groups. And actually, some of our sessions we've done with regions, we've also included patient. I was going to say representatives. I don't think that's the term nowadays, is it? Patient partners involved in some of those conversations. So certainly they were right at the forefront of that development of the model. But I think there's another bit in terms of the implementation locally, clearly where those pathways need to be reviewed with them to make sure they're suitable.
Thank you. There's a question around equity of access, which I think we'll leave until after Liz has done her presentation, because it links into the health inequalities piece. But hearts and minds for clinicians, particularly when it comes to routine day case versus specialist complex, particularly for an anchor organisation who tends to get the more complex patients. How is that addressed?
Sorry, Tim, you taking that?
No, you can say that. Happy for you to say that.
I missed the beginning bit of the question. Sorry, Kathy. So it's about the complexity of day case.
Yeah, so this is from Joanne McCallum at Newcastle upon Tyne Hospitals. Keen to understand the hearts and minds piece for clinicians, particularly when it comes to routine day case versus specialist stroke complex, and particularly for anchor organisations who tend to get the more complex patients. So
I'll start with that, Graham. So thanks, Kathy. I thought you were introducing Liz, actually, I had to say, because she popped up on my screen. So what I'd say about that is that it's been a really interesting journey about where we are, because I think what we're going to do is, if we do this right, we're going to get a double win. And what I mean by that is that we know the cases that we should have been doing day cases, and we know that we were not doing those and we were bringing them in as an inpatient, and therefore a patient who needed that inpatient bed was being disadvantaged. If we get the day case rates right across these 29 specialties at 90%, then the double win is that we're going to free up the inpatient bed for the more complex work. I think then the question is, if we're looking at the high volume, low complexity work, then one of the things we're beginning to look at now is the non-elective work, how we keep going during the winter months. We're working with the Royal College of Physicians on that. We'll have something to show for that, I hope, in the next couple of weeks. But also it allows us to look at the low volume, high complexity work. So for instance, in my specialty, already we're setting up networks across the country for revision hip and revision knee, for shoulder replacement, ankle and an elbow replacement. Again, something that would never have been thought of even 2 or 3 years ago. And the key, and one of the drivers that has really worked well, is the consultant passport across the system, allowing consultants to go and operate in different organisations. And one of the things I've always been told when I did GIRV was, Tim, our patients are different. Well, do you know, they aren't that different from everywhere else. I know you smile, Kathy, but it's so true, isn't it? Our patients, yeah, they're different. They're more complex. Well, actually, that's not the case. What we can do is the basket of cases that are agreed by BADS, can all be done as day case. It's better for patients, get them out of hospital, safer, get them home, and then allows us to do the more complex through the inpatient beds, and keeps our patient flows going as we try and attack this huge waiting list that we've all got to get over.
Thank you. Yes, I was laughing because we often hear about the evaluation. Yes. It's done on populations that aren't the same as ours, therefore that evaluation doesn't count. Yes. I think we've got 2 more questions I would like for you to pick up, and then we'll mop up anything else at the end in with Liz's questions. So the first was around from Carl Brennan, saying that it's I totally agree, it's a possibility to have higher expectations of our training and of our system. Do you agree that we need to properly design care around patients rather than see them as a volume of activity that needs planning in tranches? Delivering one excellently designed pathway 100 times is the mindset we should be cultivating, not delivering 100 operations.
Yeah, I think if you get the pathway right, as we're demonstrating, as we've demonstrated in London, then not only will you get if you get the pathway right, you will find you'll have happier patients with better outcomes. You'll reduce your unwarranted variation, your complications, and actually you'll become very much more efficient and effective, and it will also improve training. So the pathways are crucial, and we've now got 29 standardised across the NHS. We've got the non-elective to come, and therefore I think this is a watershed moment actually for the NHS to standardise care at the top decile, not the average anymore, and then build on that year on year. And already, from some of the data that Graham's shown, in your region, in NC, you're doing some great stuff. Absolutely some great stuff. So why don't we just learn from who's all doing it great and introduce it?
Can I just add to that quickly, Kathy, just on to Carl's question? So I think part of this is, so if we get those pathways right, then you reduce a lot of the rework. So you reduce all that rescheduling, the rebooking, the chasing around on the day, the cancellation. We're safe on the day of surgery, but it also it frees up the admin and managerial and clinical time to actually provide that degree of personalisation where it's required. So to me, it's about getting the basics right to enable that more personalised approach.
Thank you. And you've begun to touch on this, which is a question that Helen Barker is asking. What things in hindsight didn't work well and what you do differently, as that will help with local conversations? Oh, you're on mute, Tim.
Graham, do you want to start with that one? What do you think we didn't do well?
Sorry,
Graham?
Sorry, my Wi-Fi is dipping in and out a little bit. So what didn't we do well? Well, so I think we've had to build things concurrently. So we've had to do things whilst we've been working. So, for example, we would have been great if we got some of the procedure level data up front to start with, and actually we're kind of having to retrofit it a little bit. I think the key for me, just in terms of going forward, or what we did do well, was rooted in the clinical and operational realities of the ground. It wasn't us in a kind of back room developing pathways and then coming out there. It was a more bottom-up organic approach, and that helps with the engagement and makes it feel real. So I think I certainly think that's a really important point.
Graham, for me, Kathy, for me, if you said what didn't we do well, we started with the ones with the specialties that we thought we could make the biggest impact quickly. So orthopedics, because I'm an orthopedic surgeon, and cataracts and ophthalmology was the second one because we had a really good team around us. What I think we should have done, we should have also focused then on the clinical networks for the other 5 specialties, which we delayed somewhat because we wanted to get it up and running. But now I think we talk about the high volume, low complexity work. All we're asking for now is to have excellent clinical outcomes across those 6 specialties, but also we want to use the facilities well so that we have good managerial and clinicians working well together. So for me, it was getting the conversations with the clinical networks going a lot earlier to build those up while we were building the whole thing structure around it. So if I'd had the time again, I would have done that much broader, but I just wanted to prove it. But now we've got it. I think one of the great things is we've got the pathways. We know how to develop these networks. Clinicians want to stand up to the plate, and the data's there. So for me now, it's a win-win for all of us if we get it right.
Thank you. Thank you very much for that. That was incredibly interesting. And we're not done with the questions yet, because I'm sure that more will come up as Liz is talking or as people reflect on what you've said. So I'm now going to introduce you to Liz Lingard, who's leading on health inequalities for the North East and Yorkshire NHS England and Improvement team. Liz, thank you.
Good to see you, Liz.
Thanks, Tim. Nice to see you and Graham as well. Kathy, I have to say, Teams has just thrown me out, so I'm going to turn my camera off and hope that we stay with you for the duration of the call. I'm just going to share my screen now to show you some slides and run through not only what we're doing in the region, but also what's happening nationally around the health inequalities work, because I'm sort of supporting this work across all the different work streams within the North East and Yorkshire, and have met many of the colleagues on the call today with the work that we're doing there. So we're very keen that as we build back with everything that we're doing, that we're building back fairer and that we've got inclusive elective care recovery. It's fair to say that during COVID, a harsh light was shone on the inequalities that we have across the country, not only for people living in the more deprived communities, but also for people who are from minority ethnic groups and also have other health inclusion factors as well. And what we can do in the NHS is probably a fraction of what we need to do overall in society, because a lot of the issues that we need to look at bedded in the wider determinants of health. And I know the AHSNs have been very supportive in this area as well, especially under the strong leadership of the work that Richard Stubbs is doing, very keen to look at economic recovery alongside what we're doing around our health recovery of services as well. So what we're trying to embed across the northeastern Yorkshire is a common narrative around this work. So it's not just about people understanding the difference between inequality and equality, but it's around health equity. So just doing the same for everybody isn't going to cut it. So in the bottom left-hand corner there, it's about providing people with reasonable adjustments so that everybody can achieve what they need to achieve. So this doesn't mean the same for everybody. This means understanding what's happening within your population and providing services that meet the needs of your population. Now, most public health colleagues of mine that work out in the local authorities say this is putting a band-aid on what's happening. And there's no doubt that we must fix the system as well and make sure that going forward we offer equal access to both tools and opportunities. But there's no reason why, when we're building back better, we can't have two of these things running at once. So we're very keen that as we build back fairer, and we have an equitable approach to what we're doing, working alongside our colleagues to advocate and support for them as well in what they're doing with the wider determinants of health. So most of you will know that there's now a National Health Inequalities Improvement Programme that's led by Bola Awolabi, and they had 8 urgent actions that were published around last August, September time, which in the planning guidance this year were distilled down to these 5 priority areas. And that's very much about restoring NHS services inclusively, with a real focus on ethnicity and deprivation, mitigating against digital exclusion, ensuring data sets are complete and timely, in particular that we have ethnicity recording for everybody. But I would go further to say we also need to be better about recording who's on a learning disability register, who's got a severe mental illness, and other health inclusion factors as well. That we're accelerating our preventive programs that proactively engage those at the greatest risk of poor health. And in this, we really look around 5 areas that they've looked at: continuity of care for maternity care, earlier diagnosis of cancer, support around respiratory illness, especially driving up COVID vaccinations, flu and pneumococcal M's, looking at cardiovascular disease and earlier detection of heart disease and hypertension, and also improving health checks for people with learning disabilities and severe mental illness. And very keen to strengthen the leadership and accountability across all organisations within the NHS and have very strong system leadership, which I'm really pleased to say across northeastern Yorkshire, all 4 of our ICSs have very strong clinic leadership around health inequalities. So her triple aim is not just about equitable access, it's about ensuring that people have an excellent experience and we optimise their outcomes. And by this, I think we use that narrative that learning disabilities use, that we're making reasonable adjustments and we're providing culturally competent services to ensure that we're getting the best outcomes for the needs of our population. And as I said, she's thinking that the role of the NHS is going to happen at 3 levels: as a commissioner and provider of healthcare, as part of the integrated care systems, and also in our role as anchor institutions. And again, we've got some really excellent examples of how the northeastern Yorkshire ICSs are working really well towards the anchor institution contribution that we're making. So she's looking at this work through a number of domains and lenses. As I said, ethnicity and deprivation really driving the work, but also looking at other inclusion health groups, especially having a focus on people with learning disabilities and severe mental illness, and the life course conditions, and our contribution to wider determinants. As a region, this looks like a mess, because it's fair to say it is a bit of a mess, but there's no mistake in us putting at the top of this chart the fact that the people who are really going to make this happen are our communities, working alongside voluntary sector organisations, the local authorities, together with our provider collaboratives in the NHS, what's happening in our primary care networks, and also the other sort of work that's happening with our organisational health inequality leads. So it's these system level operational groups that are going to make this happen. And then within each of the ICSs, they're setting up some very strong leadership and accountability to drive that work and make sure that addressing health inequalities is the golden thread that runs through all the work that we're doing. So in the centre there, we have a coordination group that's co-chaired joint SROs with Jonathan Slade, who's Deputy Medical Director, and Rachel Johns, who's Peter Kelly's Deputy for Public Health England. And then we have links into each of the ICSs. Now, Jill Simpson's working very closely with this work, and we would say if we get our job done, that we should make ourselves obsolete by the time that we move into ICSs taking over their statutory responsibilities by April next year. But we're really impressed by the level of work that's happening across our systems. And that's joining up with what's happening in Public Health England, with the health and wellbeing teams, but also with their local intelligence teams and the work that they've done to develop a CWorks platform, which is about COVID consequences, want it, know it, share it, where we're putting up a lot of our health inequalities resources, as well as developing communities of practice and webinar series with them. They also link in very closely with our directors of public health forums and the other public health networks that are across our region. And again, obviously, we can't do this work without our partners like the academic health science networks. And we're really pleased to see that Yorkshire and Humber have a round table for population health management where Jill and I can drop in and make sure that this work's all joined up. Also, our applied research collaboratives in both regions work very closely together. And the ARC in the North East and North Cumbria is the national lead for health inequalities as well. So we've got some excellent partner organisations within our region, and we want to make sure that we join that into the work that we're doing on the right of this chart with NHSEI program leads, making sure that we have that common narrative from the top down, from what Richard Barker is saying at management exec and with our ICS leaders, all through the other programs that we do. And we're also, all of these arrows are double-sided because as much as we're trying to embed the guidance that's coming down from the national team, we're also pushing up where we think there are conflicts in what's coming down through the other national programs and making sure that at a national level, BOLA's working with all of the other partner programs to make sure that we have a really clear narrative and joined up approach to this work so that hopefully going forward, we're not getting people dropping in the chat, and what about health inequalities, that's already part of the narrative that comes down from all of our national programs. So as I said, these are the partners that we're working with. And again, you know, really pleased to have such strong partners in our academic health science networks. You're light of foot and can get things up and running sometimes much quicker than we can do in the NHS. So that's great to have that. But again, sort of the other teams that we're working with, making sure that we've got a read across into beneficial changes network as well, really closely working with clinical networks and alliances because we want this work to be clinically led as much as possible, and working closely with the North East Leadership Academy to do work with that, as well as Health Education England, to make sure that we've got resources that are easy to access and easy for people to do as well. So just if we're sort of really focusing on who's most at risk, I think sometimes when people talk about health inequalities, they go straight to protected characteristics like age, gender, disability, race, etc. And really we're trying to broaden it out that people are thinking more as well about socioeconomic status, and with that real focus on people living in the most deprived quintile, we can think about what this means to people. But we know that we've also probably got the largest geographic region. I know that my GIRV regional director in East of England used to tell me in East Midlands that her patch was greater geographically, and I'm not sure she's been around with a wheel on a stick to measure that, but I'm sure we're bigger. And we're the last thing north before you get to the wall. So we have some real issues with people then being able to access services due to the distances they have to travel. And it also has a great impact on them having Wi-Fi access and good Wi-Fi access. And I think members of staff who've had to work at home have really struggled with this if they don't have good connectivity there, let alone the economic means to buy these devices and pay for contracts to have that sort of access as well. We're also looking at people who have poor literacy or poor health literacy. And then there's a much longer list of people who fall into these health inclusion groups. And although disappointing that they're all not name checked in the national policy, we know that these people who face other health inequalities are more likely to live in our most deprived communities or more likely to be from an ethnic minority. So in truth, going with that focus in our first year is the right thing to do. We know that these things don't happen in isolation, and we have intersectionality of these factors. So where they all come together in the middle, where people have protected characteristics, they're also in a more deprived community and have other inclusion health factors, as well as living in a rural area, it's a perfect storm for them in terms of the challenges they face. And we know that this social gradient happens through the life course as well, and it's an unlevel playing field. for people that are coming in. So that's a real challenge for us to not only acknowledge that, but to think about how we address that. We also know that we have greater levels of deprivation across the northeast and Yorkshire alongside northwest. We're second only to the northwest. And what this chart shows, because there's a lot of focus now on people living in that most deprived quintile, but you can see, although nationally 20% of the population falls into each of these quintiles, for us in the northeast and Yorkshire, it's actually 31%. And as I said, second only to the northwest, where it's over 35%. So we know also within our region, we have massive variation from York with 4% of their population in this most deprived quintile to Hull, where it's 55% of the population that's in this most deprived quintile. But even within York, we know there will be pockets of people who live in very deprived situations and have real challenges as well. And for some, that might even be a greater challenge for them, given that they're not in sort of the majority and it's not well recognised, the challenges that they may have. We also know that COVID has shone a real light on differences in the outcomes for people who came from ethnic minority groups, and the King's Fund was commissioned to do a report on this. And although they felt with primary care there was equitable access for ethnic minority groups, it was less consistent once people were referred on from primary care into other services. We also know that even though people may have equitable access into primary care, it was felt that they were more likely to report being in poorer health, having poorer experiences of using health services than their white counterparts. So we've really got to try and get beneath what this is telling us with data and numbers and talk to our communities, engage with them and really listen to them to see what it is that we can do to make this a better experience for them and ensure that they have equitable access to be referred on to services, understand where the barriers are, and that we're really optimising outcomes for them as well. In our region as well, we're really keen to look at what we can do to level up health opportunities for people with learning disabilities. We know that this disproportionately affects them in terms of their treatable causes of death and their life expectancy as well. And when the slides go around, if you click on the little diamond there, that was developed as pathways in secondary care for elective, non-elective admissions as well, that was developed by our North East and North Cumbria Learning Disability Network. And they're really sort of exemplary thinking that they've done around that. And they are reasonable adjustments that people can make to make sure that it is an equitable experience for people with learning disabilities coming through the system. So what do we know about our region as well in these challenges? We know a little bit more about the demographics. When we've met with our colleagues in academia, Jill Rowlands works at Newcastle University and has done sort of geo-mapping of health literacy. We know that 64% of adults aged 16 to 65 in the northeast find health information too complex. It's slightly better in Yorkshire and Humber, but only slightly at 60%. And with the health literacy, this isn't just about understanding written text, it's about understanding numeracy as well. And I think never before have we been thrown so many facts and figures and R numbers and statistics without thinking too much about how much that's landed with people and have they interpreted correctly? Have we checked with them? And we still have people switching off to the messages that are coming out because they just don't find that information accessible. We also know that there's some real issues around access to digital. And it's great to see there are initiatives happening where we can get, digital services out to people. And to be honest, it's been fantastic to see how much we've really accelerated access to virtual services. But what we do know that there are a lot of people who cannot use the internet without help. We also know from some work that James Prentice has done, he's an anaesthetist in Newcastle hospitals around prehabilitation services, that the people living in the most deprived communities that they want to support to address all of their sort of comorbid conditions before they come in for surgery and help them to wait well, living in the most deprived quintile can't afford the data. If they're doing an hour-long class, that's a gig of data. They just can't afford it. So he's really looking at ways to have Wi-Fi enabled iPads that we can give out to people. And he's really, I think, wrestling now with O2 and other providers to see how we sort out the contracts for making sure that nobody gets stuck with the bill for this going forward. So all those sorts of things we've got to think out. We know that all of our systems in Yorkshire and Humber have done a lot of work with Habitat around digital inclusion. We know Humber Coast and Vale have got a bus going around to help support people to access this. So we've got all sorts of innovative work underway, and we really need to keep the eye on this to make sure that we're levelling up as we're going more digitally. We also know from this work, and this came out of work that was done in Sheffield University, and they know from this survey that they did, and I have to say this was a survey that was done by interviews rather than a written survey, so that they know that lower health literacy is linked to people who are more socially deprived without educational qualifications, people from ethnic minority communities, especially where English may be their second language, and if they've had a limiting health condition or disability. So I think what's interesting in that chart on the right is when people were asked if they had difficulty understanding written information or discussing health concerns with doctors and nurses, although overall it's 1 in 5 and 1 in 4, and much higher in our most deprived communities, even people in our most affluent communities, who would have higher levels of health literacy, found that information inaccessible for them. So we've really got to think about how we're putting out our comms, and that engagement work with our communities is really key to make sure that people understand where they need to go in this changing world after COVID. And we're really keen to do this work, especially around urgent and emergency care, but it should cut across everything that we do. And again, this just really highlights that people who have very high health literacy are more likely not to have long-term conditions. So actually having good health literacy is protective against developing long-term conditions, where it's almost the flip. And we see sort of 75% of people with low health literacy have one or more long-term condition. So how do we apply all of this to elective care recovery? So we were part of a round table that Vin Walker led. So Vin is the medical director for London that Tim and Graham spoke about, working closely for the high volume, low complexity work. And Bowler tasked Lynn with setting up a task and finish group to look at what should be the advisory note that goes around making the health inequalities gateways for elective recovery framework. And we were really keen to get involved with this. And I can see Helen Barker's on the call and she's commenting, and it'd be great for her to come in at the end as well, because Helen was part of this roundtable discussion, as was Martin Wilson from Newcastle Hospitals. We had Chris Snowden on, who's our GIRV clinical ambassador in the region, and he's also the clinical lead for anaesthetics and perioperative medicine. And from that, an advisory note came out. And the headlines from that were to consider what were the key enablers and foundations for success. And this was really systems at an ICS level, having single oversight of the waiting list, and also that this was happening at place level, that we were using population health management work to identify disparities and against sort of specific risk factors, looking at it for deprivation and ethnicity, and also looking where we could at inclusion health groups and location. And again, this work's been really well done by Calderdale and Huddersfield, FT. They've been able to segment the data. They've been able to look at differences in waiting times for people, not only from more deprived communities and ethnic backgrounds, but also people with a learning disability. And we're trying to replicate that. We know Humber Coast and Vale have used their methodology, and others, like Newcastle, are also doing similar work with that. But to do that well, we need to have access to population health analysts, and we need to start to drill down to a specialty and PCN level data as well. We're also working to make sure that everything we do when we're looking at data is clinically led and clinically underpinned, because you can go down a rabbit hole if you're just looking at numbers and you haven't got your clinicians there saying, wait a minute, this just does not make sense. So really clear that in the work that we're doing, that we've got Chris and Mark Lansdowne, who's our other GIRV clinical ambassador, helping us to think about how we present this data. And then again, this has been asked in the questions in the chat about how do we make sure that these are personalised, culturally competent approaches to not only sort of the clinical way in which we manage patients, but also the operational management. So how are we booking people in for appointments? How are we checking that a virtual appointment is appropriate for them? Can they access that? Are they living in a place where they can have a confidential conversation, even if they could have a virtual call with the sort of pre-work up that they do before they come in for surgery as well. And then making sure that we're embedding the personalised care planning approaches into everything we're doing. So we're really closely linked in to the work that's happening with that as well. So these were the key principles, the 8 key principles that came down from this. We know that The waiting list data, there's a national dashboard coming with that. We know the data quality isn't fantastic. There's a submission that trusts have to put in for that. And the first submissions they put in did not have ethnicity and deprivation, so we couldn't cut it through a health inequalities lens. We know that's improving. We're concerned about some of the coding around procedures and things like that, because we know that changes over time and as patients come through. So we know that when we're looking at activity that's happened, we know what procedures it has happened, but it's not as clearly recorded in waiting list data as well. So, and then when we break it down to specialty data, and again, I can show you some slides where we've done that, but we do have some concerns about specialty level data as well, because we do know as well that different trusts code activity to different specialties, and spinal surgery is classic, especially around spinal injections, could be coded to trauma and orthopedics, could be coded to neurosurgery, could be coded to anesthetics if it's pain management consultants doing those injections. And I know Mike Hutton's really keen that everybody codes to a spinal surgery code that's a 108 code, so that will improve it. But again, that's complex, and we need to again work with clinicians to understand what's the best way to present this. But again, as we say, if we're looking at disparities in access to this, we need to also be working very closely, not only with clinicians, but with patients and communities, so that they're getting the right messages and they're not thinking that as we move forward, this is disadvantaging anyone from any groups. So we're just asking people to look at what they're doing around waiting well. We know that there's a lot of work happening with that, and that there's regular monitoring of patient treatment lists with effective communication between primary and secondary care, and that every patient knows who to contact if their conditions worsen, and they know that they'll have a high quality conversation because it will be culturally competent. So just if we run through some of the things that we're doing, as I said, we're looking to understand what's happened pre-COVID with elective care activity by deprivation and ethnicity. And the initial work that we've done has really focused on the deprivation quintiles. So working not only with NHSEI analysts and our system analysts, but also with our Public Health England analytical team as well. And as I said, bringing in our GIRV clinical ambassadors and increasingly looking at forums to how we spread this out to clinical networks and alliances within our ICSs. So this is all very new work that we're doing. The next step is to really do a lot more engagement with clinical leads. We're also really keen that this is part of the pathway improvement work. So great to hear Tim and Graham talking about that. We've had assurances from BOLA that this will be part, so there'll be a common narrative coming down from our national teams. We also know there's the evidence-based intervention program, and some of those evidence-based interventions are also the high volume, low complexity procedures as well. And we just really need to make sure that it's all joined up and we come out with a common narrative around what we're doing around this, so that we don't get distracted and end up, at counteracting what each other are doing. We also are working with our SpecCom colleagues, because again, that's part of the pathway. When a patient enters a pathway, they don't know if they're going to have a SpecCom procedure or a CCG commission procedure. So they're the same clinicians and they're the same patient population. So we just want to make sure it's all joined up. And again, as I've said, Caldwell and Huddersfield and Newcastle have done some fantastic work that's informed the work that the advisory note that came out. And we're also looking at examples of where trusts have been able to link their waiting list data to primary care data. And we've got a couple of examples where they've done that. Again, James Prentice has been able to do it to link up waiting list data with primary care data with 3 PCNs in Newcastle to identify which people have maybe diabetes that's uncontrolled, and they can get them into interventions while they're waiting, so it's not going to delay them coming in. And again, we know that that's more likely to happen with our more deprived communities as well. We've done some work with PHE and NHSE analyst team around developing capacity to do health inequality impact assessments. There's a recording of that webinar, and we're thinking about how we develop sort of drop-in sessions to support people to understand how to do this for more sort of focused areas of work rather than just across the whole board of elective care. We're also looking at understanding what happens across the pathway of care. So it's all very well to look at inequalities in terms of what's happening with activity or what's on the waiting list, but we need to go upstream to see what might be delaying people going to see primary care about a health issue, what may change whether or not they're referred on, and then what changes them being able to attend, maybe DNAing, maybe cancelling, and then what happens at that outpatient attendance. Are people equitably being referred on for diagnostics or listed for procedures? And it's understanding all of that. And that's a massive piece of work that we're doing. And at this stage, we've linked up with some academics in Keele University who've done some work around MSK conditions in primary care to think about how we might do that, because that's one of our large volume specialties. And we know there's lots of evidence around that. And it's a personal sort of interest of mine and work that I've done as an academic before. So I think that will be a really interesting piece of work. There's health literacy resources up on the CWorks platform as well, as a recording from a webinar that we did there. And we're working with the Leadership Academy to sort of strengthen what's happening with our leaders across our ICSs. So just to sort of flag the issues around looking at this through a health inequalities lens, and we've just put up there all of our CCGs in North Eastern Yorkshire. And as you can see, the massive variation in what this means to a CCG in terms of the capacity it takes to turn the tide. If your most deprived quintile has inequalities and you have to level up, the challenge for moving 1% of the most deprived quintile for Hull is enormous compared to Vale of York, where it's 3-4%. Again, if we look at where our ethnic minority groups are living, mostly clustered in West Yorkshire and Harrogate, especially sort of Bradford and North Kirklees, we know that that percentage is higher than some parts of London as well. And again, you know, for the other parts of our area, it's more sort of Sheffield, Leeds, Newcastle, Gateshead as well that we're seeing it. But again, with others, very low diversity. But we can't take our eye off this, and we need to be mindful of that when we're looking at the data, we understand where these populations are. Again, if we look at our quintiles, remember we showed that chart that showed that across our region, 31% are in the most deprived quintile, and then it goes to sort of 17% and down to 15% being in the least deprived quintile. But actually, if we look at the population pyramids by age, there, if we look at the percentage of the population in each age band, you know, starting at the under 5s, going all the way up to 90 plus, you can see these population pyramids look very different. So we know in our most deprived quintile, it's a younger population. Part of that's higher birth rate, part of that's a much higher premature mortality. And as you go through those 5 quintiles, by the time you get to the least deprived, we've got a much older population living there. So that in itself will affect the rates of surgery, depending on the epidemiology of the conditions that we're seeing coming through. So for things like trauma and orthopedics, especially when we're looking at joint replacements, we know that that's happening around sort of late 60s, early 70s, the majority, that's on average. So you would expect to see higher rates in the less deprived, whereas the least deprived, we won't see as higher rates, even though the need may be greater because we've got a younger population. So the charts that I will show you that show rates are crude charts at this time. We haven't adjusted for age yet, and we need to be really careful about how we interpret them. So when we've looked overall at our activity for 2021 financial year, which was a mad year, you can see here we've split this by what was done in NHS providers and what was done in our independent sector providers. So it was quite high. You can also see that 89% of the activity was day case activity, with only 11% being ordinary elective, which is admitted patients for that. And we also know that the independent sector provided about 8% of all day cases and 9% of all ordinary electives. It'd be interesting to hear from Graham and Tim what the percentage is in London, because I think we've got quite low. And actually, if we split off North East and North Cumbria, it would be even lower for them, and it's much higher in Yorkshire and Humber because they've got far fewer independent sector providers in the North East and North Cumbria. So the other thing to think about 2021, it was a different year. The independent sector took on doing different specialties and more complex cases due to COVID limiting access to our NHS providers. And in some instances, we had our NHS surgical teams going out and working in independent sector facilities, especially for more urgent surgery. So as we go forward, we're always looking at our pre-pandemic year. We're looking at how we recover, but noting, you know, what may have worked well for some of these specialties going forward. I think the other thing that, as I said, I'm really concerned about is how we interpret the specialty level data. And again, really keen to get Tim and Graham's thoughts on this, because we know that some data is coded to different treatment function codes. So when we've gone beneath the specialty level data, for instance, we know that carpal tunnel releases could be done by trauma and orthopedics, plastics and neurosurgery. The bulk of them are done in trauma and orthopedics, but there's quite a fair whack done in plastics in particular. And we also know that things like GI scopes can be coded to gastro, general surgery and general internal medicine. And that when you look at activity data, it will weight some procedures that we would think, is that actually even an intervention or a diagnostic? It will weight them the same as having a joint replacement, for instance. So we've got to be really careful about how we look at it. And it would be much cleaner if we could look at things through procedure pathways rather than specialty level. But having said that, we will show you a little specialty level data. So what we've done here to understand this, and I've put red all over this, I know the recording's going out and people might share the slides. Please, can I ask you not to crop the slides? You need to put the red warning on this. These are crude rates, and we need to interpret them with caution, especially as we've seen previously, that the age profile of each of our deprivation quintiles is very different. And we know, depending on what procedures or what specialties that we're looking at, that will vary. But it's fair to say, if we look at everything in the round across, if we're looking at all NHS activity, we've cut it by deprivation quintiles, with the blue line being the most deprived, red second, green's third, and then we've got sort of black and yellow who are almost on top of each other, yellow's fourth, but black's the fifth or the least deprived quintile. So that's actually rates per 100,000 population. And then the dotted lines in the back, the percentage difference from the regional average. So if every quintile had the regional average rate of surgery, they'd all be on 0. So what's really interesting here is, even though as we went into COVID, all the activity really shut down, 10% of our most deprived population had this, lower rates of surgery. And that, as we've built back, has stayed the same. So it's frighteningly consistent across all of that. What we've done below is put the numbers in that have changed. These aren't goals. Please don't think of them as being aspirations or performance measures. It's just to show the size of the challenge. And this is what we're saying is, this is how many more people in 2021 would have had surgery to level it up, and how many fewer would have had to have it in the other areas as well. If we look at the independent providers, I think what's interesting here is, again, the inequalities are much greater. And if we look at the most deprived, it's running at about 20% lower. What's interesting here is that they seem to have recovered and are doing sort of similar level activity to what they were doing pre-COVID, but those inequalities have come up here. Again, just remember, this is only about 8 to 9% of the overall activity. So compared to what's happening in our NHS providers, it's just a slice. And what's interesting is here is we're still not back to full recovery in all of our NHS providers yet. If we look at it by day cases, again, this is much wider. And when I've spoken to Chris Snowden about this, he said, the 3 reasons why people can't be day cases are if they've got complexity, which we know if you've got lots of comorbidity, you might have, and you might not be able to be done as a day case. If you develop a complication and then you convert to admitted patient, or if you don't have a companion or somebody to take you home. And we know that this happens in our more deprived populations. They don't have transport to get home. They don't have somebody to help look after them, things like that. So we also know that there are some pockets of good practice where they're working with voluntary sector organisations to see if we can support people to go home as a day case, which I think would be a really great thing to look at to improve our day case rates, but also make sure that it wasn't delaying care for people who might in previous times required an overnight admission because they just couldn't safely get home that day. When we look at NHS day cases, again, we see that, it's running at just sort of below 10%, but when we split it out to independent sector, it's almost double, it's more 20% here. Again, they're the ones that have recovered the most, but actually the inequalities are widening more there. It's only 9% of our activity, but we really need to think about what we're doing and work with the independent sector to make sure that they're levelling up at the same time. It's different from ordinary admissions, and by ordinary admissions, I mean admitted care. We didn't have as wide a variation prior to COVID. During the crash, it sort of looked like it was going to come together, but actually as we've come out, it's still running a little bit higher. And again, this is only about 10% of our activity. It's different if we look at it in the NHS, it's really quite tight. And then if we look at ordinary elective admissions that are going into independent sector, again, it's almost 40% lower for people in the most deprived quintile. And the bulk of the activity that's going into the independent sector is trauma and orthopedics, that for admitted care would be our hips and knees that are going in. So we really have to think about maybe how we level up and get beneath the data to understand what's driving this. Is it actually patient preference? Do people not want to travel? Can they not travel? And how could we help to support them with this? And then just to look at a couple of specialties. And again, you know, if I could say it writ large, I'm kind of worried. I should have put the red line across the middle of this. But please, if you're sharing this, we do know once we adjust for age that these quintiles do come together. And part of that is because if you look at the age profile for our lowest quintile, it's a much younger age profile. So we know that a lot of these orthopedic procedures are done in later years. So it could be that patients aren't getting through to surgery. It's the different case mix. When we adjust for age, that will close in. But it also begs the question, should people from more deprived communities who have more complex conditions be accessing surgery earlier? And again, what we see for ENT is the flip. And this is really interesting. Here you'll see our most deprived quintiles at the top. Again, this is under adjusted crude rates, and our least deprived is at the bottom. So the one thing I remember from the ENT visits with Andy Marshall is a third of the activity is for children. And as we saw with that lowest quintile there, they had a much younger population. So we almost expect that they would be having higher rates, given that they've got high rates of that. So when we adjust the age for that, we might see this come together. But much lower volume specialty and much, you know, smaller inequalities as we're building back, still a ways to go. So just to sort of recap on some of the things that we just need to be cognizant of all the groups accessing services who are at most risk of health inequalities, applying a population health management approach, really keen to share where this is happening in different pockets and how we can support people to do this, that we're co-producing healthcare services. So the work that people have said about engaging with communities and patient groups is really important, especially sort of our LD networks, as well as ethnic minority communities. Our local authorities have set up amazing community hubs to support people to be shielded during COVID and to improve vaccine uptake. They're the same people. We need to work a lot closer with our public health colleagues in local authorities to understand how we support these people who are in these most deprived populations or ethnic minority groups. And we need to have a sort of a proportionate approach to what we do around waiting wells. So we have a universal offer, but we're really targeting that support and making sure everybody has the wraparound care with personalised care teams to make sure that people aren't deteriorating on the waiting list, or if they are, that we're pushing them forward. And I think it's really important that we do a lot of public comms work to get these messages out. It's going to take a long time for us to recover all these services. We need to take the population with us and the MPs, that includes our MPs as well, that we're not going to start derailing this by people coming in when we know it's the right thing to do. And as I said, we're trying to really link up. If we don't know it, we don't have to know it. We can link up with our other colleagues across the system who know what to do. So we're just trying to make sure that we have a system that is cognizant of these issues, that everybody working as an individual or as a team is reflecting on their behaviour, what more they can do to do this. And we're really wanting people to listen with curiosity so that as we recover our services, we build back fairer. And so we're really sort of doing a call out to people to listen, learn and level up. And if you're doing something good in your area, please shout about it. Please let us know. We really want to share it, and we really want to work with you and make sure that this is embedded across everything we do. Thanks, Kathy. Apologies if I've gone over. I'm not sure of the timings.
That was fascinating, Liz. Thank you so much. Really, really interesting. And as people have said in the chat, when you start looking at some of the issues, really quite concerning. So we have some comments around the from the GIRV sort of hangovers from the GIRV conversation that include health inequalities, which I think you very much touched on in your presentation, but just an opportunity if you wanted to say anything else around increased travelling assistance, increased travelling distances, reducing equity of access for the more vulnerable, and whether you had any opinions on that.
Yeah, so this is an issue with SpecCom as well, and I've spoken to SpecCom colleagues and they said it's not just having the offer to go somewhere else as well, to go to an independent sector. Some people don't want to do it. And they just said we need to do some more engagement to understand people's preferences. Some people from those lower socioeconomic groups don't want to go beyond their home trust. Even if it's a day case, they want to be somewhere if something goes wrong that somebody can go and visit them. So that's why I think we need to work really closely with our public health colleagues to look at some behavioural insights work. So we know in London, people were happy to travel for cataract surgery and that worked. But we know there have been other barriers. So I'm not sure it's the actual geographical distance or if it's concerns about going outside what they know. We all think that everybody's reading about this and they understand this, but that's why I said I think we have to get some targeted comms out and really work with our communities to understand that it's safe to go to somewhere that's not in their backyard, that there's support to get them there. And there's support to get them home, and they're not going to be left sort of marooned there. And I don't know if it's myths that they've heard about people going off and, being stuck, way away from home where they couldn't get transport to see them. But this also came up with the breast surgery visits for GIRV, that they found that people, I believe it was in Doncaster, would rather have a mastectomy than go to Leeds for chemotherapy. So I think we can't just think it's all about the distance. We've got to think about what other behavioural factors are at play here. But it's a massive piece of work that we need to invest some time in doing.
Thank you. And that touches on the comment that Helen Barker made around an issue with transport only provided if there's a medical reason rather than socio-economic reason, which we then saw differential rating times by BAME and IMD, which we are now addressing. Helen, I don't know whether you're willing to come in and just talk a bit about that, because I know that Kerry Lynn has also asked whether there's been any review of the transport infrastructure.
Yeah, absolutely. I think ours was cataract, and the provider that we had was probably about 12 miles away. And it was only when we started, which is my comment around, you have to look at what's left. So my anxiety with some of the GIRV stuff, it's very much focused on how many widgets have you done. For us, the inequality issue came out when we looked at what was left on the waiting list. So we found that we started to get a very differential waiting time by BAME. And we know that for us, the higher of the patients in IMD group 1, 2 and 3, 60% of them were our BAME patients. So actually there's a real correlation, and when we've looked into that, it was because the provider was only providing on the back of medical. And so we've now, our response to that is say, any contract that we're doing, we're making sure that actually we build transport in on socioeconomic grounds and not just on medical grounds to facilitate, which you're starting to see an impact of in terms of people now taking some of that up. But it's only because we look at our waiting list by IMD group, by the p-value from the clinical prioritisation, by the IMD group and by BAME, and we do that for every specialty. We look at it every week, and we can see where some of that variation goes. So certainly from a CHFT perspective, we've based our recovery programme based on health inequalities lens rather than just the longest time waiting, which you then have to manage because actually we're going slightly out of where our 52-week position is. But we're at the moment just looking at whether we can get a matrix together between the clinical prioritisation and a health inequalities type of prioritisation. So if I just use an example of really interesting conversation with a couple of orthopaedic consultants, one who said, you just need me to manage the waiting list. I'm looking at it on what the patient's procedure, and another colleague saying, But actually, I've got, for example, a gentleman on my waiting list who's on a 0 hours contract, manual worker, and is the only wage earner in the household. And he's a P4 on his clinical prioritisation because he's waiting for routine shoulder surgery. But with a health and equalities lens, I need to do him first. And so, and for us, I suppose, it's around, it's okay to have that really healthy debate. And we're getting into some of that type of conversation at the moment, but we're doing it because it's really focused on making sure you understand your waiting list and you've got your data by IMD, ethnicity, learning disability, etc., etc.
I think that's really important, Helen, and there's something about collecting that data because, as you say, somebody on a 0 hours contract as well has to put the beans away and the rice and the cat food and everything to plan for their surgery. If they're having something that they're going to have a period of rehab afterwards, if it's a taxi driver needing a knee replacement, it's going to be a couple of months before they get back to work. That is a massive impact on their life compared to somebody who's retired and living in a leafy neighbourhood in a bungalow who's got somebody driving around everywhere. And I think a lot of our surgeons would much rather prioritise the waiting list based on that need, but they've been stopped from doing that because of the 52-week wait. So I think we need to change that conversation, really support that work. And just to say something really controversial, I just think people with learning disabilities, really small proportion, less than 1%, let's just bung them all to the front of the list. It would be great to have a regional consensus on they just go to the front of the list. They are tiny numbers. And we know that for that person, it is devastating for them. I don't know, Helen, is that too mad to say something like that?
No, and we've done that. So actually, by the end of this month, all of the patients on our waiting list with a learning disability will have had their surgery. And we committed, that's all adults. We've then discovered you've got to look again at children because there's a difference between complex needs and learning disability. We will have cleared that cohort. And now we're putting an individualised plan for every patient from referral. We'll have an individual priority pathway. We will not do clinical prioritisation for patients with a learning disability. They will automatically be prioritised. That's our trust standard.
Fantastic.
I'm looking now at homeless. Actually, our next cohort is actually that there's something around the homeless population and what we can do in terms of something different for them.
Helen, do you just want to remind everybody which trust you're from?
Calderdale and Huddersfield Foundation Trust.
Thank you. And Sarah Berry has asked whether it's possible to share a link to the research that you mentioned around waiting lists and transport. Sarah might want to put in the chat specifically what it was, because clearly I was so engrossed in the question that I forgot to make note of what the research was.
And the other fantastic thing you've done, Helen, sorry about this isn't the Helen Barker show really, is working with admin teams for them to understand their unconscious bias when they're booking people in and things like that. So are people skipping past somebody who it might be more difficult to have a conversation with to get them in or whatever? And, you know, it's human nature. They're under pressure. They've got to fill theatre lists and things like that. And I know, and that's something you can't just do once. You have to keep revisiting. And that's why I think if this is the culture of our organisations, we've got a real chance to crack it.
Absolutely, and I suppose I'm still not convinced, if I can be controversial on this, that we've got a connection with the GIRV work and health inequalities, because standardisation, we know from even this conversation, can drive inequality. And I'm in the whole GIRV pack. I can't really see anything that directly links health inequalities with this, so I think there's still more for us to do. Yeah, and you're absolutely right, Liz. For us, it was really looking hard at those patients who deferred, and so I've done health inequality presentations and learning and education with our admin teams as much as I'm doing it with the clinical teams. But we've gone back round all of those patients who deferred to really understand why, and part of that is having some bespoke admission pathways. That means you don't have to isolate and do your swab and because actually for some that was just stopping them coming in for surgery. So it's just around making sure that you've got enough flexibility. So standardisation is great, but you've got to have enough flexibility in that to meet the individual needs.
Yeah, it's reasonable adjustments. Are Tim and Graham still there? Are you going to jump back on and reassure us? They've gone.
Unfortunately, I have to leave at 10:30.
Oh, okay. Sorry, didn't realise that. That is a real shame. But I have to tell you, Helen, the other thing that we're worried about is there's the evidence-based interventions program as well. There's pathway improvement program, as I said, the high volume, low complexity. But we're working closely with Chris and Mark, who are embedded in that as our GIRV clinical ambassadors. We just keep pushing it back up, saying you guys need to come out with a common narrative. And you all need to be cutting this through a health inequalities lens and looking at what you're doing. And if you're widening health inequalities, we can't juggle things that are cutting across each other. And you're right, we can't live with building back faster if it widens health inequalities. We're not going to do it. And I think we're looking to Owen to stand up and say that. But we know other people will cave. There'll be enormous pressure on systems. So we're really keen to do as much as we can up front to support systems so that we've got a really compelling narrative about why this is the right thing and what we're doing to close the gaps.
Thank you. And that plays into to a question from Carl Brennan. Do we need to simplify the asks of our teams with plans or intentions built around guiding principles? For example, does the plan reduce variation? Does the plan reduce inequality? Is it sustainable?
And I'd say we start with is this plan going to increase health inequalities? If so, what are you doing to address that? So the EBI team have said they've done a health impact assessment. I'm not sure the pathway improvement program or the high volume, low complexity work's done a health impact assessment, because if they did, then that would flag up all the things that we're raising. So we will do that within our region, and we're sort of working with our public health links in PHE and in the ICSs to think about how we look at the impact of some of these things and to mitigate against it. But a lot of it is digital by default, just puts the little hairs on the back of my neck up because it's exclusive by design. So I think we have a real challenge, and we have to look and say there's not equitable distribution of resources to do this work. So the North has got a much greater challenge, but then if we hold the mirror up to ourselves in the northeastern Yorkshire, do we give out resources where we're doing it equitably? And the pushback with the small p that we get from that, if York got a lot less, then it's a real challenge. And what we just need to do is come together across our systems to make sure that this is underpinning everything we're doing. And we're constantly holding the mirror up to ourselves to say, are we being sort of a hypocrite if we're challenging the national team when we ourselves within our sphere of work, how big or large or small that is, aren't doing that.
And that links into a question from Joanna McCallum. We have real digital challenges in doing this work across the region. How are we linking this in?
So we've got Steve Furman, who's our regional director for digital, and that because that was part of the 8 urgent actions around inclusive digital, each of our systems have done work around that. Habitat supported that work, and we're constantly looking at other initiatives to do that with. Is it digital first primary care or primary care digital first? With that program as well, they're looking at different ways to make sure that's inclusive. Saw a really good little YouTube that came out of somewhere in West Yorkshire and Harrogate that was an animation and had subtitles and somebody signing to explain how to do that. But I have to say, it's possibly part of the reason why we're seeing such an influx of people into EDs, because they don't have digital, or they can't use it, or they don't like it. It's one of the three. And they just want to see somebody. And you know what? If I go and stand outside an ED, eventually a person will talk to me. But if I phone up somebody or go through the 111 online or do an e-consult, I may never speak to somebody. And we've got to tease out how much of that is due to just high levels of anxiety, stressful lives, anxiety and loneliness. But then there's the real need for people to get to see somebody as well. So again, we can't make judgments about that. We've got to do the hard yards and do some engagement work with our communities to understand why they're doing that. And if everybody does like digital, what's interesting in the outpatients data, the virtual appointments, there's very little difference between our IMD quintiles. But if you look at face-to-face, we have much higher rates of face-to-face with the less deprived, which doesn't make sense. That's not need. That's being a pushy person to say, I just want to be seen. Mm. So that is a worry.
Thank you. Two other questions that have come up in the chat. Kerry Lynn asked whether the health literacy data that you had in your presentation, Liz, whether that could be made available at more local levels.
So there was a little link to the geo data that goes down, I want to say to LSOA, but I'm not 100% sure, it might be MSOA, but that link will be there. And if people sign up to CWorks, which is a sort of a PHE and HSEI joint platform, we've got a health literacy folder up there, and we're trying to develop a community of practice, because it's not just about making information in an accessible format. We also want to encourage a love of reading to improve people's literacy skills. And we know Marcus Rashford's doing that with children and young people, but we'd like to make it an evergreen offer so that anybody, any age, can find the resources or the support to learn to read, to improve their health literacy. Because as I said, it's got such a strong protective factor against developing long-term conditions. So we've linked in with Health Education England. They've done things like Teach Back, and I think it's Chunk and Check and things like that. So it's some really short videos that you can watch about ways to improve conversations and materials to make sure that people can understand them. But all of that would be on CWorks. So I'll send through the joining instructions for how to get onto CWorks, Kathy. I think it's the best thing, and then access the more detailed resources beyond what's in the slides.
And then we can circulate them. Thank you, Liz. And then a question from James Patterson. Is there a risk that by moving patients across regions for treatment that you lose some of the expertise managing an established patient population with specific needs? Jake, I'm not clear whether that related to GIRV or whether it was specifically about something that that Liz had mentioned earlier. So Jake might not be on still. Here we go. Mostly about GIRV. So it's entirely possible that that Liz, you don't want to answer that, and I completely understand why.
Leave that to Tim and Graham.
Yes. And then there was one other one where I'm afraid, Thomas Hollins, I don't understand all of the acronyms, but identifying HPLC and also low volume, high medical complexity needs and separating them on operating lists will improve efficiency and outcomes for both groups. But we will need to prioritise the time for LVH medical C. Thomas, excellent, you've appeared.
Yeah, sorry about that comment. It's so much easier to put acronyms in text, isn't it? I was simply just saying that we got a lot of the IMD population with additional needs have got higher medical complexity. Liz pointed that out really well on her slide set. And that actually, I did see there's value in the GIRV presentation of the high volume, low complexity operating lists and getting through those. But actually, we also need to clearly prioritise operating lists for those with higher medical complexity, which include a lot of people in the BAME population and those with additional needs.
Yeah, I agree, Thomas. And I think, and putting the social stuff alongside that, because what we know is they're more likely to have social issues that they'll need support with. And I think trying to join it up with the local authority community hubs, and I know in County Durham and Darlington, they've linked waiting list data to primary care and local authority data, so they know people are on benefits or who may have had to shield or needed food boxes and things like that. So they know up front who's going to need that additional support to get through. But I couldn't agree more, because those people are much more likely to develop a whole raft of other complications as well.
And is there linking across wider government? So just thinking about Department for Work and Pensions and Ministry of Justice, who I know have programmes around people living troubled lives.
Yeah, once you try to get DWP or something like that, it's like asking for the crown jewels. It's really hard. We work, Best MSK Health have got a whole piece of work around data and analysis, and I'm linking in with Neil Parkinson, who's leading on that work. But they're pulling in data from Keele University and other colleagues who've done some mapping to look at access into primary care and look across the whole pathway. So yeah, you'd really want to know that. You'd want to know which people are on benefits as well, and how you help that person to access support to come in and things like that. I think a lot of us think NHS is cradle to grave and it's free at the point of delivery. But actually, if you can't afford to be off work for the time to come in, and this isn't necessarily just people from deprived communities. If you're a dentist or a high street optometrist, you don't get paid for the time you're off and things like that. So I think we really need to have a much better understanding of all those factors, and that forms part of the screening and prioritisation that comes through. But yeah, the real risk here is we're going to leave behind the people who've got more complex needs, as you've said, Thomas. If it is just about activity going through, that is the real worry, that those people with more complex needs, where it will be devastating for them not to have timely surgery, will really widen the gap.
Thank you. That has been an incredibly interesting presentation, Liz. Thank you so much, and thank you to all the participants, because having the conversation in the chat really adds something to these events. So thank you for being so keen to share. Thanks also to Tim and Graham for another fascinating presentation around GIRV. And it's a shame that we don't have the opportunity to pull out some of the constructive comments we've been making during this part of the conversation, but perhaps that's one for another discussion.
Yeah, we've got the other members of the GIRV team on the call, Kathy. I've seen Helen's on, and Val and Michael and Jen, I think, and it might be if they can relay the questions back to Tim and Graham, something can go out with the notes and the recording just to answer some of those questions, and really keen to work with them to make sure this is all joined up.
Yeah. Thank you very much. Have a great day, everybody. Thank you all again. Bye.
Bye.